Thanks for tuning in to the Women's Vibrancy Code, a podcast dedicated to helping women move from exhausted to energized, balance their hormones, and feeling turned on by their life, their lover, and themselves. I'm your host, Maraya Brown. I'm a Yale and functional medicine trained women's health expert, midwife, mom, keynote speaker, and self-made entrepreneur. I'm the founder of my signature program, the Women's Vibrancy Code. So sit back, relax, and let's chat about your energy, hormones, libido, and embracing your feminine power. Oh, and you might want to have pen and paper to take some notes on some of these episodes. I am thrilled for this conversation for lots of reasons, mainly because we get to really get into the nitty-gritty about the topic of endometriosis, which I think as you're going to listen, you'll realize it affects more women than we even know. And the fun story, I have Dr. Kerin Orbuch on the call with me today. So Iris and I were both flown out to the Big Island of Hawaii to explore this retreat center. And they flew out, I think there was 8 of us that are female leaders around the globe that host retreats. And we got to be wined and dined and have this great experience, but it was also an opportunity to meet some really amazing women up to really cool things. And I definitely leaned into Dr. Kerin Orbuch. I'm going to call you Iris, to Iris's work. And this is one of those topics that I just feel like needs to be brought to the world. So Dr. Kerin Orbuch, author of Beating Endo, How to Reclaim Your Life from Endometriosis. I'll make sure to grab that link and I'll put it in the show notes. Is a fellowship-trained endometriosis excision surgeon out of Beverly Hills. She sees the value in addressing endometriosis, an inflammatory disease, via integrative approaches. So I want you to hear that already. She's already said endometriosis is an inflammatory disease, and we're going to be talking more about that. So the cornerstone of endometriosis treatment is surgical excision. However, Dr. Kerin Orbuch incorporates a whole body approach that combines Eastern and Western medicine in getting her patients on their road to recovery. She regularly collaborates with health practitioners, including nutritionists, pelvic floor physical therapists, pain physiologists, gastroenterologists, acupuncturists, and naturopaths, as well as integrative medicine physicians, in order to help heal her patients. Though she loves treating all patients, Dr. Orbuch's passion is helping teens and adolescents. And one of the things I just have to put in there, I had no idea, we're going to talk about this, but she let me know that they're now understanding that endometriosis is actually genetic, and they're finding endometriosis cells in newborn babies. So we're going to talk more about it. But Dr. Orbuch is focused on improving women's health through science, policy, and education, and currently serves on the AAGL, which is American Association of Gynecologic Laparoscopists Foundation Board, and was the former president of the AAGL Endometriosis Special Interest Group. She's an active member of the Washington, D.C. Society for Women's Health Research, Endometriosis Working Group. Wow, I'm getting tongue twisters. Beyond numerous published articles and chapters and extensive lectures. Dr. Orbuch's medical advice and guidance is relatable and has been quoted in, ready for it, drum roll please, Cosmopolitan, Vogue, Allure, WSL, CNN, US News, National Geographic, Marie Claire, Washington Post, NPR, Stylecaster, People, Ethos, Romper. I could go on and on. First of all, welcome. And tell us a little bit about the documentaries that you've made as well.
So my passion has been raising awareness about a disease that is so common that so few people know about, and the few people who know about it know about outdated, disproven information. So I have been working for almost 2 decades. How do I raise awareness about this really common disease? It's just not letting those who are suffering live their lives to their fullest. So I collaborated with Shannon Cohn, who's the producer, and we worked on the first movie, which she's a brilliant lawyer turned film producer at NYU, went to NYU Film School, and we basically have been trying to tackle the problem. And so she's such a smart woman. She studied the AIDS movement and the breast cancer movement and said, how did they tackle breast cancer? How did they tackle AIDS? Like, who has AIDS anymore, right? It was an epidemic. And how did that all change? So first you have to educate, then you have to do like a social movement, right? So the first movie was so low budget. It was like such a lonely road. It was like her and me and like a handful of people, all these naysayers. And we premiered the movie in 2015 after so much work. Really just, that's an educational movie, very low budget. It actually went around the world, that movie. And that movie was the beginning of a train that is now moving. And then through all of that was born the second movie, Below the Belt, which was released on PBS June 21st. It premiered at the MoMA in New York last May, so 2 Mays ago in 2022, has been all over the world, including screenings in Congress this past March. And that follows 4 women with endometriosis who are telling their stories. It's tugging at hearts and minds. And it's really, it's just, now people are coming out left and right. I have endo, I have endo, I have endo, and people are willing to talk about those things that are really, were unfortunately taboo, hush, hush, like my younger daughter, one of her first words was uterus, for uterus. Like for me, it's very important that my kids have the vocabulary. That's my vagina. I'm comfortable using these words. So we're destigmatizing everything, raising awareness, empowering, and it is amazing. We were just in DC in June before the PBS launch, and again, meeting with bipartisan. We have bipartisan buy-in, and basically, hoping to get more funding. And that we had our first endometriosis coalition in DC. I'm going back in September, and it's amazing. The movie is the producer, Hillary Clinton is a producer, Mae Whitman, Corinne Fox, Rosario Dawson. Am I missing anybody? But we have bipartisan funding, bipartisan support, Elizabeth Warren, and right now, why am I blanking on his name? It'll come to me. I can picture him, but it's just amazing. It's not a partisan issue. It just so happened Hillary Clinton, it like spoke to her, and she came to the New York premiere.
Mm-hmm. And so it's called Below the Belt.
Below the Belt, yeah.
And I mean, there's so many things that I'm sure you strike me as someone that just wants to climb to the highest mountaintop with the biggest loudspeaker and just announce to the world. On the podcast, there are women listening all over the world. And so if you would say, okay, let's start here. Here are like the top 3 things that I wish every woman knew about endometriosis, where would you start?
Yeah, I think I'm going to talk about the symptoms, because the symptoms, people don't even know what the symptoms are. Endo can affect every organ system. So people usually think of it as a period disease, but in actuality, the patients who I see most have been incorrectly diagnosed with IBS. They have either constipation or diarrhea, and or alternating constipation and diarrhea. They have bloating. Some have painful bowel movements. They could have one of those symptoms or all. They end up like selectively like, oh, that bothers me, that bothers me, that bothers me, that bothers me. We're limiting what they're eating. Anytime they travel, they're a mess, because the littlest anything in their system that's going to like jolt their system just, sets them off. Many can have gynecological symptoms, such as you can have painful periods. You can have pain preceding your period, after your period, mid-cycle, which is ovulatory pain. You can have pain all month long. Painful sex. It can be entry, deeper penetration pain. Some people have urological issues, like with urinary frequency, urgency, feeling like they have urinary tract infections, but their urine cultures are coming out normal, fatigue, exhaustion, and then also from the gynecological realm, infertility. So some of those who suffer from infertility, where the doctor calls it quote unquote unexplained infertility, that means sperm looks great, egg looks great, don't know why you're pregnant, which is pretty much most of those who are suffering with infertility. 40 to 50% of those are because of endo. So that's one. The symptoms are different for everyone. You could be a twin and have a twin sister. Your twin sister just has mostly gut issues. You have no gut issues. You have just GYN issues. You could have a triplet. She just has urological issues. You could have a fourth, quad, whatever. And they're totally asymptomatic.
Yeah.
So everyone has different symptoms, and two, it's an inflammatory disorder. So it sets off interleukins in the body, which are inflammatory mediators that really affect every single part of the body. It then causes lots of gut dysbiosis, leaky gut, small intestinal bacterial overgrowth. And then those with endo have higher likelihood of autoimmune diseases. So it's an inflammatory disease. Three, we don't see it on imaging. So when your doctor says, go for an ultrasound and says, oh, it's normal, there's nothing wrong with you, that's just not true. We don't pick up endo on imaging. You can, if someone has a cyst of endometriosis on their ovary, that does get picked up on imaging, but in general, imaging is usually normal or negative. And the only way to diagnose it, I can tell with like a consult with 90% likelihood whether someone has it, but true diagnosis is actually a surgical diagnosis. And then from the surgical treatment, 99% of doctors are doing the wrong surgery. So they're doing the wrong surgery is ablation or burning of endometriosis. Do not recommend it at all. That's what I learned how to do in my residency. Before I then embarked on a fellowship in excision of endometriosis. It's a removing the implant that's inflammatory, that's like wreaking havoc on your whole body. So excision surgeons are hard to find. They are there. And I think lastly, I would say, trust your intuition, trust your gut. If you know something's wrong with you, find a specialist.
I heard you mention gut dysbiosis. Curious what you think. What comes first, the chicken or the egg? So what I heard is that it might cause gut dysbiosis. I'm curious, could it also be the other way around, where someone has a gut dysbiosis, which then causes the endometriosis or worsens the symptoms? Or is this literally something that the majority of women who have endometriosis are born with it?
So that's such a great question. So what we do know, there was a study of female fetuses where the mom's pregnant with, and I just want to use inclusive words, by the way. So when I tend to just go towards the word women, I'm just talking about anyone with a uterus, however someone identifies. But when a mom is pregnant with the daughter, and let's say there was a car accident, blunt trauma to the abdomen, and there was like a fetal demise, the fetus passed away, they found that 9% of female fetuses actually have endometriosis. And that number is not too dissimilar than what we quote in the general population of roughly about 10%. We'll truly never know the true incidence of endo because it's a surgical diagnosis. So I would love to take, 10,000 women and just scope them and see what's there. We're just not going to do that, right? So yes. So if the mom has endo, the grandma has endo, the aunt has endo, a sibling has endo, that daughter, granddaughter, niece has a 7 to 10-fold likelihood of having endo. That means a 70 to 100% likelihood. Now, it's hard enough in 2023 to be diagnosed. Imagine how hard it was one generation ago. So very often the family history is, oh yeah, she had surgery. They removed her uterus. She was told she had fibroids. She was told she had cysts. Like that's usually the history. And back then, like doctors, like male doctors were doing these surgeries weren't even telling the women what was going on in the surgeries. So, yes, we know it's genetic. We also know if there was no family history, exposures to dioxins, which are byproducts of bleaching, plus a whole host of other exposures in utero, can cause endometriosis. So that's two. And I really believe the gut is the brain of the body. There's a study that came out recently about different bacterial elevations in those with endometriosis. I really believe that they're onto something. So many in the endo community were like big naysayers about it. I'm like a fighter. I look at things. I don't know if anyone read Adam Grant's book, Think Again. Okay, very interesting book. I read it with my book club with my girlfriends. And the book isn't like a quick read by any means, but it really challenges you to think like a scientist, right? And anytime I get information, I look at that at every different side of the coin. And I think that's why I started this whole thing almost 18, 20 years ago about a holistic, multidisciplinary approach to endometriosis. Do you think they wanted me in the surgical organization? I'm a surgeon telling people to do pelvic floor PT, treat your gut, find a pain psychologist. Like, they were not so welcoming to me. Can I swear?
Yes, you can.
I don't give a fuck because I beat to my own drum. I don't live in a box. And I'm trying to help people. And I really knew I was onto something almost 2 decades ago, the more and more I did about a multidisciplinary approach. Guess what? Everyone's talking about multidisciplinary approach right now, you know? And guess who's on the board of the foundation board at my international organization? Guess who was the president of the endometriosis organization, special interest group? Because I will fight what I believe in, but I'm not blindly believing in something. Like, I'm looking at everything like a scientist trying to understand it. Anyway, so this paper that came out it was just a very small group of people with different, looking at different gut bacteria, and they were finding certain bacteria, I think, in the uterine lining of those with endometriosis. And listen, they know that all autoimmune diseases are coming from the gut. MS is coming from the gut. Parkinson's is coming from it, all of it. And endometriosis is an autoimmune-like disorder. And there are certain bacteria that they now know of. If there's too much of this bacteria, it's a higher likelihood of MS. All of it's probably coming from, is it like too many stresses to the body? Is it a food poisoning? Whatever that thing is. So I do believe in time that we are going to find improvement. And there was even a study that came out with NAC, Laura Bryden you were the one who sent that to me.
I tagged you on it. Laura Bryden had posted something on Instagram, and I'm like, Iris, you got to see this.
Yeah, and it's so interesting because I take NAC myself, and it was just a very interesting paper. And I thought it was very well done, taking it 3 days a week for, I forget however many months, and it helped decrease the size of an endometrioma, increase pregnancy rate. These are all beginning initial studies, but like, it's what I'm doing and seeing in my own practice. So I do believe that there is going to be, NAC is N-acetylcysteine. I saw someone post that.
I often refer to it as NAC, but I think there's a lot of protocols out there from an anti-inflammatory perspective. NAC, it helps with methylation, it helps with detoxification. So Dr. Laura Bryden had posted a study specifically with NAC and endometriosis, and so that's what she's referring to.
So the endo community went berserk with that study and was like, no, that's bullshit. No, I don't believe in that, blah, blah, blah. But again, like in Adam Grant's book, it's like, what kind of a thinker are you? I am that thinker who's looking all the way around something. And anyway, so I do believe in value in anti-inflammatory stuff and gut. And I do think that in time, hopefully it's in my lifetime and I get to see it, we will find the link and the bacteria that's kicking this into.
Well, and I just have to say you're speaking my language, and it's one of the reasons why I brought you on. Anyone, I mean, obviously this is also in the Women's Vibrancy Code. They're all getting gut dysbiosis testing and hormone testing and adrenal testing, and it is a multidisciplinary approach with a functional dietitian and a mindset coach and a sexologist and a trauma release specialist, and that's why one of the reasons why I left brick and mortar.
Yeah.
It's fascinating to me. I was just, we're in Arizona right now staying with family, and, it's one of those neighborhoods where you have to be 60 or older to own a home, and all the rules and the times where the kids can be at the pool, and having conversations with a number of people that I'm tired of hearing. I went to my PCP and I asked about something that was cardiac in nature, and the PCP won't answer the question. You have to go see your cardiologist for that.
Yeah.
Or I asked a question that was around my lung cancer and whether or not I want to do chemo, and my PCP won't answer that question. So even in mainstream medicine, there's this, like, it feels like even further fragmentation where there's just this very narrow lane. And so I'm always looking for, where are the experts in the world that, first of all, are open to be open thinkers, acknowledge that we're a unique puzzle, there's lots of different factors, and be open to step out of the lane a little bit and acknowledge all the different things that are at play. So it sounds like we're hearing that it's genetic in nature. They're saying about 9% of fetuses will show endometriosis cells or signs of endometriosis, about 10% of the population. And if you have any family member with a history of endometriosis, there's a 7 to 10-fold increase. And yet, how are we supposed to even know if we had a family member, if that family member was older? Because the symptoms can be as vague as painful periods, painful sex, urinary frequency, fatigue, exhaustion, infertility, IBS, constipation, diarrhea. Like, that's every woman. And then I'm hearing, okay, an ultrasound isn't going to pick it up yet. As a practitioner, often an ultrasound is what insurance will cover. So now the question is, what do women do today? For the woman that's listening to this who says, my PCP says it's not a possibility. They've only ordered an ultrasound and everything came back normal. Here are my symptoms. I have family history, I think. Where do I start to try to advocate for myself? Where do I start to explore someone that will do an endoscopic peek? And where do I find someone that is really trained to do the right excisions?
That's a good question. So this is kind of why I wrote my book, because Beating Endo, How to Reclaim Your Life from Endometriosis. And I wrote it because I wanted it as a manual, as a guidebook for patients who are not being heard, to go into the doctor's office, to open that page. My patients come in with my book tabbed, highlighted all over, to then challenge the internist, the PCP, or whoever with the proper information. So also in the back of my book, I have a whole host of resources of where to go, where to get information, because most of the information online is all outdated. It's all drug, like big pharma, who's trying to sell their drugs for these medical management. And the whole, like, the side effect profile of those medicines is just horrific. Hot flashes, weight gain, joint pains, muscle aches, osteopenia, osteoporosis, depression, suicide. Great. Who wants that on top of all those awful symptoms? And the bottom line is, you're keeping that inflammatory tissue that's setting off these inflammatory mediators to the whole body. It's all broken. So you have to be very careful what you read online, because a lot of different support groups are funded by big pharma. So the back of my book has a whole table of contents vetted by me. I have no interest. I don't take money from anybody. I could make so much more money if I took money from big pharma. I don't. I'm one of the few people who refuses their money. I went to dinner with them. So if you see there's like $100 online, because I wanted to know about them, but no, I would not work for them. So I will not take money from big pharma. So that's I would say start with the movie Endo What, which you can get off endowhat.com. It's like $10 to download it, and 100% of the proceeds go to put a copy of that movie in every school nurse's office across the country. I think so far we're at don't quote me on this, but I think over 5,000 schools have toolkits and posters, and the nurses are educated. So that's where like the $10 or so goes. Then you can stream on pbs.org. I think it's still available. The movie, you just under the search bar hit Below the Belt. That's a second great place. My book has really everything. I'm not trying to sell my book, but I put together everything as a manual or a Bible for patients to, have information. It breaks down. There's like a chapter on mind body, a chapter on, pelvic floor PT, a chapter on like every single thing, gut. So this way you can go to the GI and say, well, she says do SIBO testing. She says do this. She says do that, to then challenge those practitioners to get the prescription for pelvic floor PT. Then it tells you how to find a good pelvic floor PT. It's a manual. I cannot see, there's a 200 million suffering from it. I can't see that many people. So I wanted to give, some people's books really suck because they don't give you the keys and the answers and the tools to get better. This has it all in there. Okay. I want to make the world a better place. I recognize I can't see all those people as much as I would love to. So this is a manual that will guide your care.
Mm-hmm. And so I hear loud and clear that you're specifically passionate about reaching the younger population. And many of the women that listen to my content are in their 30s, 40s, 50s, 60s. Yeah. I'm wondering, some of them might be saying, well, crap, too late for me. I've lived with this my whole life. So what do you say to the age range? Is it a curable thing? Like, are there actual those success stories of I suffered all these decades and now it's all gone?
I would say at least half of my patient populations are 30s and 40s, maybe 60%. When I started, 90% were 30s, 40s, and I have some 50s also. I'm passionate about getting teens just because I'm trying to pick it up early. So all of the early awareness is because I'm trying to educate pediatricians so people don't get picked up in their 30s or 40s or 50s. But like I said, more than half of my population's, 30s, 40s, and I have some 50s. It's never too late to reclaim your life. And that's why I titled my book like that, How to Reclaim Your Life from Endo. Never too late. Guess how old I was when I had my diagnosis of endo. I know I look 27, but I was 48 when I finally had my scope.
And the ironic thing in your scenario is you had been treating this and advocating for endo for so long, but yet there was a delay in your own
diagnosis. Yeah, I got my daughter treated when she was 9, my older daughter. I'm like, she's got endo. Pretty much every doctor was like, no, she doesn't. You're just thinking like an endo specialist. I'm like, no, she's got it. We went to every head of the departments at you name it in Manhattan, and everyone, no. And I just knew she did. I flew her to a specialist, and we did a whole mind body. We did everything that's in my book beforehand. So prehab, I always do that. Gut health, worked with integrative nutrition, pelvic floor PT, meditating, brought in my yoga teacher into the house, everything. My whole house is organic, EWG verified, certified. Anyways, and then she had surgery when she was 17. She wanted to wait until she got into college. That was her choice. So when she was diagnosed, I'm like, okay, my own gynecologist was like, yeah, you're just manifesting your patient's pain. I was brainwashed. I was like dismissed. I was gaslit. But mind you, I had been in pelvic floor PT for years. I'd been doing integrative every single thing I was doing. And guess who got better in the recovery room? I did. By the time I got to the recovery room, I felt better because I had tuned up my body for years and years and years. I didn't believe my own self, which is crazy because I get people to believe their own pain. So, maybe that's how I got to be where I was, that I think there's a divine orchestration for everything. Anyway, so it's never too late.
Yeah. Thank you for sharing. And And especially with the broad range of symptoms of how, so first of all, diagnosis is hard to get because it's got to be laparoscopic. And I look back at when I did my nurse practitioner training, I went to Yale, like this is supposed to be a good education. I remember being taught that the telltale sign of endometriosis is menstrual pain before she starts bleeding. And the thing to do is to put them on hormonal contraception or to use a GnRH agonist. And other than that, I don't remember anything else. And so it sounds like now
It's the
that,
same thing. That same thing is what's being taught.
okay.
It's the reason being is guess who, like big pharma is feeding a lot of the organizations, and yeah.
Don't get me started. I had to take a pharma class every semester and one nutrition class in the midst of 3 years. Did you know only 1/3 of physicians graduate from med school having taken one nutrition class? And yet they're just, oh, the pharmacology. Okay, I'm going to stop.
Yeah.
There's a question in the chat.
Yeah.
She says, I'm 55 now in menopause and had third stage endometriosis diagnosed surgically. What does it mean now for me?
So stage 3 endo. So I guess the question is, what did they do? It's not like the endo goes away. It's still there and inflammatory. So you'd want to get the operative report and see, did they excise the endo? If they ablated it, it's probably still there. And also who did the surgery. Unfortunately, endo has different appearances when you put the laparoscope in. That's our camera that we use. And I only learned in all of my OBGYN training, and I had great training in New York City. I only learned 2 appearances of endometriosis in my amazing training. In my first week of fellowship, which was pretty much all endo, I learned more about endo than I did in 4 years of residency plus 4 years of medical school. So it's just like, who's doing the surgery? If it's an OB and GYN, they don't know what endo looks like. They don't know how to treat it. They miss it. So what does that mean? It's complicated because I don't know what your symptoms are. I don't have an operative report to look at. But I would recommend, if you have any of those symptoms that I mentioned, I would, again, read my book and let that guide you to where to go with it. But
and because she's in the Women's Vibrancy Code, we're actively addressing gut dysbiosis. I know with this woman in particular, I don't know if it's okay for me to share her name because it's on the podcast. She also struggled with infertility and did IVF. So, I'm imagining there's like that wish, coulda, woulda, shoulda.
Yeah.
Had we known decades ago, maybe that IVF journey would have been a very different experience. And I'm also hearing loud and clear that all the stuff that we're naturally doing, really addressing an anti-inflammatory diet, really cleaning up those endocrine disruptors, really having a stress reduction practice of meditation, right? So it sounds like because it's inflammatory in nature, it's all the things that we think of to combat inflammation. Yes?
Correct.
Yeah.
Yeah.
And for those that are listening, I've never done an ablation. I've been in the OR and assisted in the ablation. The way I think of it is it's like this balloon that they put in there and then they put like boiling water. So it's like scalding and burning the inside. Is that how you would describe it? Versus excision is going to be going in, like, I imagine these little tiny scalpels and scissors, like just take that little bit away. And we're going to be with a lot of specificity, not burn it, but actually take the cells out.
Yeah, I like to explain it to people like, imagine my whole fingernails an endometriosis implant. Excision would be removing the whole fingernail. Ablation would be just getting the white part. Leaving the rest of the implant, which is pro-inflammatory, behind. And what usually happens, the implant usually causes the anatomy to pull this way or that way. And if you're then applying heat or burning something, kind of like saran wrap by a stove, left too close to a stove, it shrivels up, right? So if the anatomy's pulled all the way here, then you're applying heat onto it, it shrivels it up even more, buries that inflammation. It's still there, but it's now pulling the anatomy, which then pulls on the underlying muscles and the fascia. Structurally, you're not moving properly. Then you're not breathing properly. Then your adrenals are going crazy because you're exhausted. And then yeah.
Yeah. And so then the question in the chat is, you mean it doesn't actually go away? So is there actual recovery? Like, are you seeing women with full recovery? Or is this something where most women are going to expect at some point a resurgence?
So my re-op rate is 5 to 10%. That means 90 to 95% do not have another surgery. And within that 5 to 10%, those are the patients who, let's say, we're leaving some endo behind because if I excised it, I would have jeopardized fertility. So we're intentionally leaving something behind, or we're leaving their uterus, which has endometriosis in the muscle of the uterus. It's given another name known as adenomyosis. We're intentionally leaving something because of their desire for future fertility. Then they, have hopefully their 2 or 3 kids or whatever it is they want. Then if they're still symptomatic, then we go in and do something more definitive. So, did that answer?
Yeah, right. So the big thing I'm hearing is it really depends on who you see as the surgeon.
Yeah.
And who does the excision. And Iris, you and I had a lot of conversations on this topic in Hawaii, that you're kind of like beating your head up against a wall because there aren't a whole lot of great ones out there. And so then how do we educate them, and how do we bring in pelvic floor PT and make it a more multidisciplinary approach to address the inflammation? But the other thing that I just heard you say that it feels really important for everyone to hear is endometriosis is not just in the uterus. So can you specify between adenomyosis, endometriosis, and where are you finding these cells?
So endometriosis by definition is external or outside of the uterus. So endo is not found in the uterus. So like, to take one step back, endometriosis is when we have endometrial-like cells outside of the uterus. So meaning cells that are similar to the lining of the uterus get thicker and thicker each month and then shed. But those cells are found outside the uterus. They're not identical. They're similar to. And then, so what happens month after month, like your hormones are telling your uterine lining get thicker and thicker and thicker. Then if you don't get pregnant, 2 weeks later, you shed that lining and start it all over again. Those cells that are outside of the uterus that are endometrial-like, they're similar to the endometrium, are also getting thicker and thicker, but there's no exit point for them. So they just get deeper and deeper and deeper, causing more inflammation, more pain, more structural anatomical pulling, and then causing more and more discomfort. Adenomyosis is when you have endometriosis in the muscle of the uterus, confined into the uterine muscle. Now, the guidelines, our guidelines, like when you went through what you learned, one of the guidelines and treatments, and if I tell you how many patients I see who their general OBGYN removed their uterus or did a hysterectomy on someone for their endometriosis, I mean, I want to bang my head against a wall. Endo by definition isn't in the uterus. Why are we removing people's uteruses and then castrating and removing their ovaries when that's not what endo even is? So the treatment of endo is excision of endometriosis. If someone has endo in the muscle of the uterus and they've completed childbearing or don't want kids, then a hysterectomy would be definitive treatment. Hysterectomy being defined as removing a uterus with no mention to the ovaries.
And if a woman doesn't have the finances or the resources or the time, lives in a really remote place, has crappy insurance, whatever, there's stumbling blocks to seeing someone who really can do the right laparoscopic, the right excision. Does it make sense for that woman to then go on contraception? Does it make sense to explore a GnRH agonist? Just do an anti-inflammatory diet? Just see a pelvic floor PT? Like, where would a woman start if she's feeling overwhelmed listening to this, going, well, crap, now I'm destined to feel crappy for the rest of my life if I can't find a surgeon.
So honestly, before I even operate on patients, I would probably be doing 3 times as many surgeries if I just cared about the bottom line. But I care about my patients. So I do so much more prehab for my patients before I even touch them surgically. I would get them right into pelvic floor PT. I would, but in my book, it talks about how do you find a good pelvic floor PT, because not all pelvic floor PTs are created equally. Doing weekly PT for however many sessions needed. Doing an integrative nutrition approach, working like with what you're doing, healing the gut, checking for all the gut stuff. And then mind body meditation is free. It's what my patients resist more than anything. There is the concept of neuroplasticity. We can rewire our brains. I do it. I talk the talk and walk the walk. So meditating mind body, you can't meditate endo away, right? But you can chill out the central processing unit of our body, which is our nervous system, and flip the switch from a sympathetic state to like a more of a parasympathetic state. Working on anxiety. If someone's anxious and their gut is going to slow down from a transient perspective, and they're just going to have recurrent SIBO. So I would say do everything. That's what I do with my patients. See how you feel. Sometimes with my patients, usually by the time I get them to the OR, they're at least 30% better. Many are 70% better before I touch them surgically because you have to understand, in the US, there's a diagnostic delay of often a decade, where those see on average of 8 physicians over that decade. So over those 10 years, they're curling up in a ball in a fetal position in pain. They're tightening the muscles. They're then becoming constipated. They're straining on the toilet. So like their muscles are tight. They're like, there's medical trauma. Their doctors are saying you look perfect. There's nothing wrong with you. So there's anxiety. Then like there's all these things that set in. So undo all of that stuff first while you're looking for a good specialist. You can go to some academic centers. There are some great endosurgeons at some academic centers who take all insurances. So you gotta find the right one. And just like anything else, you gotta just do your research, you know?
And are there many that have done an extra fellowship specifically in endometriosis?
More and more now. Yeah. But you've got to really do your research.
And for the women listening in the podcast, I mean, they're all over the world. I think this podcast is like top 20 in Sweden and the Dominican Republic. I'm like, hey, to those of you in Sweden and the Dominican Republic, how'd you find me? But for the women who are listening and they're outside of US, Canada, are there suggestions for that population?
I mean, I have people fly in from all over the world.
You do?
Yeah, people fly in. I do virtual consults. And so I have people from all over who fly in.
Okay. All right. Okay, I'm seeing another question in the chat. So I had a laparoscopy, which ended up removing endometriosis in 2012. With lifestyle and diet changes, I am now finally off all progestins and hormonal treatments and managing fairly well. Whoop, whoop, thanks to the Women's Vibrancy Code. Okay, 2 questions. I still have discomfort and pain on day 1 and 2 in the anal area and with bowel movements. Something's over this question. I can't see it. Need to have a bowel movement. So there's question number 1. Any thoughts there? Is this likely from leftover endo from the surgery or something that can be helped with treatment?
Hard to know, but go to pelvic floor PT for sure. I'm sure that'll help.
And she does go there periodically throughout. But I think when you're suggesting pelvic floor PT, it's probably a weekly visit, maybe even more than once a week for a good chunk of time. Is that fair to assume?
Yeah, it's weekly, yeah.
For generally how long?
It depends. If someone's had pain and has been curling up in a ball and sitting on a toilet for 25 minutes or 30 minutes a day for 2 decades, can't fix that in 10 sessions. You know, you're going to need it for longer. A lot of my patients, I have patients who, they travel, they do this, and then they do the PT virtually for 2 or 3 sessions. They do dilators, they do home stuff, then they go back. So there's workarounds for everything.
Thank you. And then
Sorry.
what about online PT? I mean, they can't do
Yeah.
touch, they can't do in person, but have you found any
Yeah.
success?
Yeah.
Like I'm
Yeah.
thinking, what is it? The Vagina Whispers out of Louisiana.
So
Uh,
I know PHRC, Pelvic Health and Rehab Centers. I know they do virtual. They started doing virtual during COVID, and they actually have found it, like they were working with people in the Far East during COVID. So yeah, for sure.
Okay.
Yeah.
But that's great to know. So sounds like pelvic floor PT. And how do you think pelvic floor PT is moving the needle?
Well, and using a squatty potty and all of these things, because if your muscles are so tight, what happens is most of the patients are like they're gripping, they're living in a gripping sympathetic overdrive state. The PT will release the pelvic floor muscles.
And my 9-year-old had her first day of constipation. Mom, what's going on? So cute. Afterwards, she said, "Is that what giving birth feels like?" But we're traveling, and so I'm like, "Find a stool, come up with a squatty potty." It is amazing just to put that stool underneath, change the anatomy a little bit. So for everybody, if you're not using a squatty potty, get a stool. Keep your stool in your bathroom.
Can I add something?
Yeah.
Google the squatty potty unicorn video. I include it in every consultation I do, and I show it to my patients.
Okay.
Because the muscle gets tight, and it's like, you'll see it. It's cute. It's 2 minutes. You're going to get one at the very least.
Cute. Okay, so then her second part was thoughts on stress throughout the month and causing increased symptoms during bleeding time.
Yeah, so we know that's why part of when I meet a patient during their consultation, I always assess for stressors, anxiety, depression, OCD, trauma, abuse, whatever. And, the same part of our brain, more or less, that's modulating pain or that hurts, gets upregulated the more stressed someone is, because everything's being processed through our central nervous system. Our central nervous system is processing all pain. So the more stressed one is, the more upregulated the central nervous system is, the more kind of all of our other pains are amplified, or the pain is worse. And then that's going to cause our muscles to tighten even more as we curl up in a ball to protect ourselves. Then that causes more pain. Then that's going to cause more curling. Then that's going to slow the gut down. I mean, it's like a vicious cycle. So yes, absolutely.
I'm hearing loud and clear. Clean up your endocrine disruptors, live an anti-inflammatory lifestyle, take your symptoms seriously, address your gut microbiome, honor that mindset matters, energy works, nutrition is important, like all of that, and make sure that the diagnosis is being done correctly and the specialist you're seeing is actually trained in endo. Any last parting words from you that's like this? I want to make sure everybody really hears this.
Yeah, pregnancy doesn't cure endo. That's a myth. Hysterectomy is not the treatment of endo. That is a myth. Having a doctor tell you to drink a glass of wine, sex won't hurt, tell them to fuck off. That is not true. Sorry. I hear that all the time. It makes me so mad, and trust your gut. Like the reason our gut is like the brain of the body, it's like our intuition. If you know something's just not right, keep finding a doctor. And even in my book, it talks about once you finally think you find the surgeon, questions to ask about a surgeon. Like someone's website may say they're an excision specialist. You got to sit face to face and say, well, how many excisional biopsies do you do? Because many excision people will claim they're an excisionist to get patients. They do one biopsy and they ablate the rest. So you really have to, it's no different. If you're buying a house, you're going to get an exterminator. They're going to check the sewer lines, the water lines, this and that. I promise, do the work and look into your surgeon. And my book tells you how to do all of that. It's like I'm handing over my consult in a book.
That's awesome.
Yeah.
And it sounds like you do virtual consults. And so if someone wanted to reach out to you, I have your website. I'll put it in the show notes as well. Plus your Instagram profile. Is that the best place for them to start? And obviously reading the book, obviously.
Yeah. Just reach out and,
Yeah. Well, I appreciate you. I
Thank
appreciate who
you.
you are in the world, the fact that you walk your talk, and the mission that you're on, I know is impacting many, many women for generations to come.